All right. Thank you so much. Hello, Dr. Mittal, and thank you so much for offering this incredible opportunity for our Wayne State University students. My name is Mariana. I am the event spokesperson for Club Med Virtual, and I will be leading today's session, reading any comments posted in the chat and facilitating the conversation as we go along. Before we start, I want to remind everyone to maintain proper etiquette and please keep themselves on mute unless Dr. Mittal specifies otherwise. If you have any questions, please post them in the chat and we will address them as we proceed through the session. A Google survey will be administered for Wayne State University students at the very end of the session to verify your attendance and will close 30 minutes after the session terminates. Please stay on the call for at least 5 minutes after the session is over to ensure that the survey is working for you. This session will be posted on YouTube in case you are unable to attend or want to revisit certain topics that Dr. Mittal discusses today, but you cannot receive shadow or attendance hours if you are not present in this call and complete the survey. All right, Dr. Mittal, you can get started if you'd like.
Awesome. Thank you guys for having me. Excited to talk to you all again. This will be a good topic. So let me share my screen. Let's see here. All right, can you see it?
Yes, we can see the screen.
Perfect. All right. Yeah, if there's questions in the chat, please, you can let me know. I'll answer them as I go along. If anyone wants to unmute themselves, feel free. Not a problem at all. Okay, so let's just jump right into it then. A little bit about me. I went to school at the University of California, Irvine, here in Southern California. I was a biology major. Finished in 2009, sorry, and went straight into medical school at Touro University. It was a DO school in Northern California right after college. Finished up there and did my family medicine residency at one of the Baylor programs near Austin, Texas. And I currently work in Kaiser Permanente in Southern California. And some disclosures. This is all just examples. There's no actual patient information here. It's just my standard disclosures. I have nothing to disclose, no financial or incentives or any conflicts of interest with this presentation. Okay, so some of the topics. We were going to talk about GERD and ulcers a little bit. So the topics that we'll go over is a little bit of the anatomy, kind of what it means to have GERD and gastritis and what those terms are, ulcers, some of the medications that are used, and some of the procedures that are used regarding these two topics in general. So gastric anatomy, here is a very standard picture of the stomach. So the GI tract or the gastrointestinal tract, really we think of it as one long tube from the mouth to the rectum. It's just different sections, but all encompassing one long tract. So, you have your mouth, you have your throat, you have your esophagus, and that's when we get into this first portion of what we're really talking about is the lower part of the esophagus, the stomach, and the first part of the small intestine, the duodenum. And so, you'll see some terms that I'll mention frequently. So right after the esophagus, you'll see there's a little area called the lower esophageal sphincter that plays an important role when we talk about ulcers and gastritis and acid reflux and GERD. You have the stomach itself. You have the pyloric sphincter, which is the same idea as the lower esophageal sphincter, except instead of at the end of the esophagus, it's at the pyloric area at the end of the stomach at the beginning of the duodenum, and then you have the duodenum itself. So again, that's just the basic anatomy of the stomach. And again, on the recording, if anyone wants to go back and look at this more closely, they can do that. So GERD, we talk about GERD, G-E-R, and then GERD with D at the end, so gastroesophageal reflux, and then you have gastroesophageal reflux disease or GERD. And then you have gastritis, which is gastritis, and we'll go into a little bit more when I talk about some of the details, but gastritis is usually traditionally more limited to the stomach itself, and it is more related to just inflammation of the protective lining of the stomach rather than actual reflux. And we'll talk about what reflux means in a little bit. So right here, acid reflux. So ideally, the lower esophageal sphincter works to help prevent reflux. So basically anything from the stomach coming up into the esophagus. So that sphincter ideally should work as a one-way valve. Food should go down the esophagus and go into the stomach. Ideally, nothing should come back up, right? That's the whole idea of it. You see on the far left picture there under healthy stomach, it says diaphragm. So that's an important part of this. What separates the thoracic cavity or your chest from your abdomen? That's really just the diaphragm, right? That's the separating factor. And obviously there are holes in the diaphragm, one of those being, your esophagus, where your esophagus goes into your stomach. So there are separations there, but that is generally the what distinguishes the chest from the abdomen. So in a GERD stomach, that lower esophageal sphincter is not really working. And it says it's allowing acid reflux. So basically things are refluxing from the stomach up into the esophagus. And it's not just acid. And we'll talk about that a little bit later as well. But that's the basic idea of how this works. Gastritis, again, more inflammation. So if you do an endoscopy, meaning you put a camera down the throat and into the stomach and the lower esophagus, ideally what you'll see is on the left is a normal healthy tissue, as opposed to on the right. You can see very clearly there, it's quite red, quite inflamed. And there's a variety of different reasons why gastritis can happen, which we'll talk about later on in this lecture. So what are some of the causes, right? So a number of different things: infection, bacterial infections, but especially something called H. pylori. That's a very common reason why people have an infectious reason for their symptoms of GERD. Bile reflux, so it's not just acid in the stomach. There's enzymes, there's bile, etc. You can have an increased acid production from what quote unquote normal should be. As I said, you have enzymes. You can have a normal amount of acid and bile and no infection, but you could have a problem with your lower esophageal sphincter. And that could be the reason why you're having reflux in your symptoms. Obesity, hiatal hernia. And I think I have a picture later on of what a hiatal hernia means. Diet, spicy foods, pro-inflammatory foods, citrus, chocolate, alcohol, smoking, medications, NSAIDs. And someone remind me to talk about a case with that. I have a good pediatric case that I can run through real quick regarding NSAIDs, or the non-steroidal anti-inflammatories. Allergic, eosinophilic esophagitis, and pregnancy. And so we can go back and talk about more of some of these in detail in a little bit. But those are some of the causes. Hiatal hernia, there we go. So again, ideally the lower esophageal sphincter, as you saw in that other picture, is right around the area where the diaphragm is. And what can happen in a hiatal hernia is, again, for a number of reasons, a portion of the stomach is in the chest cavity. It's above the diaphragm where it shouldn't be. And obviously the stomach has acid producing cells. And so, what is heartburn? You have reflux up into the esophagus, and because that's where your heart should be, you feel like you have heartburn. And so if you have acid being produced in the area of the stomach that is now up into the chest, and that will obviously cause some dysfunction of that sphincter, you're going to have symptoms of heartburn there. So that's essentially what it looks like. There's various types of hiatal hernias and different grades of severity. I mean, that's something you can look up a little later, but for purposes of this lecture, that's the basic idea of what a hernia is. Part of that stomach is up above the diaphragm when it shouldn't be. Ulcers, on the other hand, it's really defined essentially as a sore or a mild erosion in the lining of the tissue. And obviously we would be talking more about, the GI tissue in this case, and more specifically the upper gastrointestinal system, not really talking about the colon and things like that. So if it's in the stomach, it's typically called a peptic ulcer or a gastric ulcer. Those two names are synonymous. It can also be in the first part of the duodenum, or the first part of the small intestine, in which case it's a duodenal or duodenal ulcer. And you can also have ulcers in the esophagus as well. I mean, as you can imagine, you have acid going up into the esophagus, you can form an ulcer there. And, why is it that, and I don't have a portion of the slide on this, it's why do you get heartburn, right? So what if you have acid or enzymes or bile up into the esophagus? Well, really, the stomach is meant, it's meant to handle that. It has a protective layer, it has a coating. Those cells are designed to withstand acid generally, as opposed to up in the esophagus. The types of cells that are there really aren't. They really just don't handle exposure to these chemicals just very well. So how do we investigate, symptoms? Really, it's based off the history in someone's symptoms. I think I mentioned on my previous lecture that I gave, you have to think about a differential diagnosis. And I'm not going to get into specifics of how to take a history and whatnot in general, but if you have you have to know the questions to ask. And usually based off someone's symptoms, you can have a pretty good idea if they're having some level of reflux or inflammation in the stomach or the esophagus, etc. But there's other things that can be done as well by various other specialties besides primary care, right? I mean, you can be a GI doctor and you can do the endoscopies, or you can have the camera that goes down and, you can literally see an ulcer, or you can see inflammation, which is gastritis. You can do pH testing, which involves having things like these small probes that can be placed during endoscopy in the lower esophagus to measure any reflux that comes up and measure the pH of that area to see if there is any abnormal chemicals and acid in that area. You can do biopsies. That's a very common way that we test for the infection. I mentioned H. pylori is by doing biopsies when someone has an endoscopy. They take biopsies in various parts of the stomach to see if there is H. pylori there. And you can also test for different things via lab tests, meaning blood tests or stool tests. How do we treat? So any questions so far? Sorry, I'm running through this. So any questions in the chat so far? No, we're good.
I'm not seeing any right now, but
Okay,
I'll
cool. Cool. We'll keep going then. So for medications, proton pump inhibitors, or PPIs for short, there's a few, as you can see by the names there, omeprazole, pantoprazole, etc. They kind of end in the prezol. That's the kind of the suffix for the names of most of those medications. Those are the generic names. So those are very common. And as the name suggests, they help prevent acid production. It's a proton inhibitor. Going back to your GChem stuff here. So I want to describe how PPIs are used a little bit. And this is how a GI doctor, all of my rotations of residency, explained it to me and how he taught me to teach it to patients. So think about the acid producing cells in your stomach like a light switch, okay? So, you wake up in the morning, right? You haven't eaten for 8-10 hours, however long it's been. Your stomach should not really be producing acid because you haven't eaten anything, right? So acid is produced in response to a stimuli, meaning food, usually. So think about your switches being off. Your light switch is off in the morning before you eat anything because, again, you haven't stimulated those cells to produce acid. When you take these medications, traditionally it says 30 minutes before eating. I usually tell people about 45 minutes before eating. Basically what they do is they help prevent those switches from being turned on. Once those switches are on, it doesn't turn those switches off. And that's an important distinction. And that's why we tell people to take the medication 30 to 45 minutes before eating, because it gives the medication enough time to essentially block all those switches. That's the important thing. So if you take it 15 minutes before and then you eat something, well, you may have hit half, a third, whatever, some level of those switches per se, and you will start producing acid. So once that switch is turned on, that block comes in here and it doesn't turn those switches off. So that is a really important, that's the example I always give for patients, and people tend to really kind of relate to that. That seems to be understandable for them. So that's how I like to describe how to use proton pump inhibitors. Traditionally, people say, it's a once a day medication. It says it's 24 hours. In my experience, my limited experience being a young physician, it really feels more like it's an 16 to 18 hour medication. So yeah, typically we start people on it once a day, usually in the morning. Sometimes we take it once a day in the evening before your dinner. And sometimes you split up the dose and say take it in the morning before breakfast and in the evening before dinner as well. So various different ways that can be administered. You also have the H2 blockers, famotidine, the generic name or the brand name that people may have heard of as Pepcid. That's another common way. And basically how that one works is a little bit different. It blocks histamine-induced gastric acid from parietal cells, and parietal cells are in the stomach, and those are what produce, again, acid. So it works through histamine blockade, which is a little bit different, but that's another one that can work. Unlike the proton pump inhibitors, it doesn't keep these switches from being turned on, so it doesn't necessarily have that time restriction of how you need to take it before you eat. So it's a little bit more forgiving, and that is fairly accurate that it's a 12-hour medication. So people can take that, fairly typically twice a day. Carafate, it's a medication that basically reacts with hydrochloric acid to create a coating around the stomach and acts as a buffer against acid. And I'll talk about that a little bit more when we come back to ulcers, because that's an important one. And then antibiotics, right? If someone has a bacterial infection, again, as I mentioned before, H. pylori, you can treat that with antibiotics. There's a number of medications that you can use. Some of them are more first line than others. Clarithromycin, amoxicillin, Flagyl or metronidazole, Levaquin or levofloxacin, etc. Those are all antibiotics that are used in conjunction with proton pump inhibitors for H. pylori treatment. You'll do that for a certain amount of time. Now, depending on where you are in the world and where you are in the country, you do have what you call these antibiotic resistant charts that you're usually, your infectious disease department would have. So you can always reference that to see what generally, your population that you work for and that you serve has an affinity for, and which antibiotics don't really work for, again, for your population in general. So there are some options in there to use.
So we actually have a question in the
Yeah.
chat from Jessica. She asked, what inclines you to prescribe one medication over the other?
Again, it depends on symptoms. So let's actually go back and do a few examples. I'll see if I can answer some of that there. So let me pull back to, wait a minute, where is it? Causes here. So let's just say, for example, I have a 50-year-old guy whose BMI is 40, so he's obese, coming in saying, I feel like I have acid reflux. Every night when I go to sleep, I feel like I have this heartburn symptoms. My diet's not great. I eat a lot of Mexican food, spicy food, Indian food, whatever. So I eat a lot of spicy food. I eat a lot of fast food, fried food type of things. And it gets so bad that I have to take Tums all the time. And that does help a little bit, but it just tends to it stops working after half an hour. So it gets so bad that I feel nauseous. I feel like I need to vomit. And so oftentimes I feel like I can't lie down flat, when I go to sleep. So I end up sitting in my recliner to help prop myself up. So, because that helps a little bit, and then they'll say something like, I wake up in the morning, I have this funny taste in my mouth. It's almost like it's like a sour taste when I wake up in the morning. Or it always happens after I have a beer, right? If I have beer and wine, that sets off my acid reflux, etc., things like that. So if someone has very kind of typical cues like that, and those are very kind of textbook symptoms for just kind of quote unquote heartburn in general. And so generally it is the first line therapy to start someone on a proton pump inhibitor based off those symptoms. Now, that is not ideally a long-term solution. There's a lot of studies and a lot of data out there, and I won't get into all the landmark studies and the typical things, but proton pump inhibitors aren't without their cons, right? They have a lot of pros, but they aren't without their cons, as with all medication, right? Nothing's without its side effects. And there are some very well-established, known, fairly serious consequences that can happen if someone is on long-term proton pump inhibitors. And so generally, when we talk about a formal trial of PPI, we really talk about 6 to 8 weeks. Someone should not ideally be on a proton pump inhibitor for longer than that. If someone is unresponsive to therapy, then you need to rethink what's going on. Let's say, for example, they have an infection of H. pylori and you don't treat them with antibiotics, you just have the proton pump inhibitor. Yeah, you may be helping with the symptoms a little bit, but the underlying problem is still there. You aren't treating that with the antibiotics necessary. So it's 8 weeks later, you give them the PPI, and that, again, that's just the first line thing that you tried generally. They're not getting better. Well, maybe you missed something. So you need to go back and look. Hiatal hernia. Well, again, same idea. You've done your therapy. Where are most people going to find hiatal hernias? Well, sometimes they can be incidental findings, and what that means, we use that term a lot in healthcare. Say someone ended up in the ER because they had, appendicitis, and they ended up having a CT scan of the abdomen. Well, part of a CT scan of the abdomen is going to capture the lower part of the chest, and oh, look, we saw a hiatal hernia there. So sometimes it can be an incidental finding. We just see it when we're investigating something else, but oftentimes, someone will have heartburn symptoms that's unresponsive to therapy. So we send them to our GI docs, they do an endoscopy, and oh, look, lo and behold, they have a hiatal hernia. And that's something that can be fixed by a general surgeon. And I'll talk about some of the procedures a little bit later. Um, what else did we talk? Obesity, right? If someone is what we call truncal obesity and they have a lot of, let's just say, a typical male pattern of where they store fat is in their abdomen, if someone's morbidly obese, that tends to put a lot of pressure on your abdominal organs. It tends to put a lot of pressure on your diaphragm. And that can, as from what we've discussed so far, lead to reflux. And that can be a very common reason. Same idea with pregnancy, right? You have a baby, as baby gets bigger and bigger and bigger and you're approaching delivery, that's a lot of pressure on the abdomen. Everything gets squished, to put it frankly, and that including the stomach, and that can cause heartburn. I'm not going to get into the allergies, the eosinophilic esophagitis. That's getting into too much detail. NSAIDs, okay, right? There are some other medication-induced reasons. Anti-inflammatories, the NSAIDs like Motrin, ibuprofen, Aleve, Advil, etc. Those are very common reasons. So one of the cases I had when I was a senior on my inpatient pediatrics rotation, I had some med students with me, and it was a young girl. I think she was about 13 or so. Was coming in for abdominal pain, intractable, meaning it wouldn't go away. We couldn't stop it, nausea and vomiting. And she was having obviously heartburn symptoms, as you normally have when you have vomiting. And when you talk about someone's history, they couldn't figure out, as we were admitting her and taking care of her within that first day, why she was having her heartburn symptoms again once we got her vomiting to stop. And one of the things that was causing her abdominal pain, because we ended up finding that she had an ulcer, was anti-inflammatories. And so one of the things that we talk about is the girls will know is that when you have a period, you can get cramps. And what do you normally take when you have cramps? You take things like ibuprofen, Motrin, naproxen, etc., things like that. And this poor girl was having such bad, awful cramps with her menstrual cycles every month that she was like taking way too much Motrin. And that's what ended up causing her an ulcer. And so, the history, as I mentioned, the story, the symptoms are very important. So social history is a very important thing, right? There's many incidences where when you have a female and she's coming with different, regardless of the symptoms that she's describing, you do want to get a good social history. And oftentimes for, young women and older women, people who are having their menstrual cycles, that includes getting a detailed history of their menstrual cycle. And this isn't an OBGYN talk, but you have to find out when you get someone's menstrual cycle history, do they have cramps? That's an important part of the puzzle as well. So there are various types of reasons, but as to the question that was asked before, again, proton pump inhibitors, that's just this first line medication. Oftentimes I will tell people to try just the proton pump inhibitor for a bit. And if that's working and it's starting to work, but it's not quite enough, you can also add in the H2 blocker or the Pepsid as well to see if you can augment their therapy that way as well.
Thank you so much for answering.
Any other questions so far?
I actually have a question. Oh,
yeah.
Sorry, whoever was asking first, you can go.
Go ahead.
Are you sure?
Yep.
Okay. Can GERD and like IBS be related? Because like I have IBS and I always also experience acid reflux with it. So is there a link in between those or not?
Absolutely.
Really?
100%. 100%. The IBS, irritable bowel syndrome, isn't necessarily just related to the colon, right? We talk about, I may have mentioned on my last talk, but inflammatory bowel disease versus IBS, irritable bowel syndrome. So you have something like ulcerative colitis, which really truly is just limited to the colon, versus Crohn's that can be anywhere in the GI tract. Similar to that, IBS or irritable bowel syndrome is not just limited to the colon. It can affect multiple areas of the intestinal tract. And one of the things that can happen, and it's variable for everyone, right? Everyone has different symptoms of their IBS and how it affects them. But yeah, one of those things can be acid reflux. It's all intertwined. So absolutely, 100%.
Thank you.
Oh, the question I had was, what are some of the negatives from the treatments? Because I know you mentioned with the proton pump or inhibitor.
Yeah,
that-
PPIs, proton pump inhibitors. It can increase risk for infections. It's not just for digestion that you have, acid and enzymes and all this stuff in your stomach. It also is a protective factor against bacteria. And if you're inhibiting production of that, it can lead to infections later. So that's something to be aware of. Brittle bone disease, etc. There's a number of different things that it can cause. And again, it's variable on how long per person you have to have exposure to this medication before you get some of these long-term effects. It can be years. And that's what comes, it's hard, especially when you talk about like electronic medical records. We have thousands of patients and we have thousands of patients with their messages and questions and medication refills. And it's such an easy thing, right? It's not an opiate. When we hear a PPI, it's so easy to just hit the yes, I'll approve a refill of it. And then you approve a refill again, and you approve a refill again, and you approve a refill again. And, suddenly it's like, oh my gosh, I've been refilling this guy's PPIs for, like 2 years now. And they truly, again, shouldn't be on it for more than 8 weeks without further evaluation, right? I mean, if someone's having ongoing heartburn that's not being controlled enough, you need to investigate it. It's not as simple as that where you can just refill meds. So you have to be very careful with this stuff, and really make sure to go back and look and say, okay, what's happening? What am I doing? Do I need to reassess? Do I need to figure out why this person is still having symptoms, right? Are they, maybe it's because they're obese and you've investigated everything else. And, if they're working on it and their weight's coming down and they're still just having lingering symptoms, well, then I might be a little bit more more liberal about refilling someone's medication for a short amount of time. But, if they're not their normal weight, we've ruled they don't smoke, they're not pregnant, they don't take anti-inflammatories. We've ruled out H. pylori as an infection. Their diet doesn't seem to be giving them risk factors for acid reflux, and they're still requiring this medication. I might have a red flag in my head and be like, I need to think about this a little bit. Something else might be going on. But yeah, you do have long-term consequences like infections and brittle bone disease, etc., things like that.
Thank you so much for answering. We also have another question in the
Yeah.
chat. So someone asked, how does bile reflux occur?
So bile is typically produced in the liver. Okay. Actually, let me find that here. It's probably back here. Okay. So bile's produced in the liver, and the liver sits in the upper right side of your abdomen, and it's stored in the gallbladder. The gallbladder sits right underneath the liver. And then you have a tube, the cystic duct, which comes off the gallbladder, and you have a tube that comes down from the liver, and the cystic duct in that tube meet into the common bile duct, and that common bile duct goes on to the first part of the duodenum, the first part of the small intestine. And so if you have not lower esophageal sphincter dysfunction, but if you have something like pyloric sphincter dysfunction, if you have bile that's being produced and released into the first part of that small intestine, because of your normal food, et cetera, whatever, and then it's refluxing back into the stomach because of a pyloric sphincter malfunction, then that has the potential of moving, up into the stomach, causing problems in the stomach. It can also move up into the esophagus and cause issues there. So that's essentially how it works. So I mentioned ulcers. Where did that go? Here as well. So let's talk a little bit about that. So ulcers, when people say that they're having symptoms, and you mentioned, there's always something to consider that you might be having an ulcer. They were like, oh, can you get an X-ray or a CT scan? Well, generally, these types of X-rays and CT scans and these type of external scans, I guess you could say, aren't really fantastic for looking inside your GI tract. Now, obviously, if someone has a massive colon cancer mass sitting in their colon, you might see that on CT scan. Or if someone has an ulcer that's so thick and so deep that it's perforated, you may see evidence of that, on a CT scan or on an X-ray. But generally, for these mild ulcers, you can't see that with a CT scan. The only way to really see it is by going down with a camera for an endoscopy. So that's how you really truly prove it. Again, I can get an idea based off someone's symptoms if it's something more like reflux versus something more like an ulcer. There are some cues that they're nothing's hard and fast. There's no hard and fast rules, but there's some textbook things that generally hold true. So, for example, it's not just heartburn, but they're having abdominal pain. So if I'm having abdominal pain after eating, well, something to consider on my differential diagnosis is there may be an ulcer. And again, I really don't know that I've seen too much of this being, again, hard and fast, but what you'll learn in medical school is the textbook thing is that if you have a gastric ulcer or a peptic ulcer in the stomach, usually after eating that your pain will be you'll have a fairly quick onset of pain after eating if your ulcer is in the stomach, as opposed to a duodenal ulcer that quote unquote textbook onset of pain is a little bit delayed after eating. So again, how often does that hold true in real life for that pattern? It's variable. I would say less often than not. But that's something to consider. If someone does give that very textbook, I have pain 45 minutes after I'm eating in the right upper part of my stomach, well, that could be a duodenal ulcer or a peptic ulcer. So that's something to keep in mind as well. So how do you treat? Really, so ulcers, let's assume you don't have a perforated ulcer which requires surgery, right? So a traditional superficial ulcer in the stomach, the body's pretty good at healing itself. And so generally, the whole idea, I guess the example I would give is you just don't want to salt the wound, meaning you want to help eliminate the factors that are making the ulcer worse so that you can let the body heal itself. And so how would you do that? I mentioned our medications somewhere. Medications. So proton pump inhibitors, right? If I have a little ulcer sitting on one part of my stomach, it keeps getting flared up because acid that's produced after eating, flares it up, makes it worse. It's quote unquote salting the wound. So you could put someone on a PPI to help reduce the amount of acid that's impacting how this ulcer heals. You can also give them an H2 blocker. It's not going to do quite the same thing, but it will definitely be helpful. But then also Carafate, and that's why I put that on there. If you can help eliminate a fair amount of the acid that's being produced, and then you can help coat the stomach, then you can essentially eliminate the cause and put up a barrier around that ulcer so it's not being further insulted so that the body can essentially start healing itself. And that's really how it is. That's how you treat an ulcer. The general ulcer you treat with medications, and oftentimes you don't need to send someone for an endoscopy to evaluate for an ulcer. If someone's coming in for a suspicion for it, not only are you giving them these medications to treat, you're also doing it as a test. So if it works, yeah, you treated them, but your tests about whether this was an ulcer was probably right, whether that be gastritis or an ulcer, things like that. So it's not only a test, it's also a treatment. So that's how that Carafate kind of fits into that picture.
So we have a question from Charles. He asked, how different are peptic ulcers from gastric, and can they be treated with the same approach?
Yeah, so the same idea. They're the same name, peptic ulcer, gastric ulcer, different names for the same thing. And yeah, they're treated just like I mentioned, generally just by helping to eliminate the acid with the PPIs and H2 blockers and giving them the coating of the Carafate. And then again, if you know the causative factor, say someone was taking a ton of ibuprofen, you tell them you got to stop taking ibuprofen. If you're having pain for whatever reason, take Tylenol. It doesn't have that effect. Or if someone is eating a lot of spicy food and a lot of fried food, okay, you got to start eating at home and not buying fast food for every meal. So again, if you happen to be able to determine the causative factor from your history taking of the patient, then you can also try and help eliminate that source.
Thank you for answering.
Anything else so far?
Not in the chat.
Okay. Invasive procedures. So I mentioned before that a GI doctor can go down and do an endoscopy and they can look, they can take biopsies, etc. But the other people that can get involved besides primary care and GI is general surgeons. And so what can happen is, again, I mentioned the lower esophageal sphincter dysfunction. You can do a procedure called a NISSEN fundoplication. And on the left, you can see a picture of an illustration of what that surgery entails. So let's assume you don't have a hiatal hernia, like at the top of that picture. That's a normal looking stomach and anatomy. You basically take the top part of the stomach and you wrap it around the esophagus, and you tie it to the other side, and you are trying to essentially reproduce the action that the lower esophageal sphincter is supposed to do. It does stop all reflux, assuming that the surgery goes well and has no complications, whether that be acid, enzymes, bile, etc. It is what we call a laparoscopic procedure, meaning they go in, it's minimally invasive. So you make, I think for this, it's 5 incisions that are just a couple centimeters, as opposed to something like a gallbladder surgery or an appendix. Those are usually 3 little incisions. This takes 5. And they're very small. They go on the abdomen in different places. And you do this all laparoscopically. If someone does have a hiatal hernia, you can fix that at the same time that you do this procedure. I've actually had the privilege of, when I was in residency, to work with a few surgeons who did GERD surgery. And I got to be a part of some of these, and it's a really cool surgery. It's quite high risk. It's not something that people go into lightly. It does have very good success rates if done correctly. Usually the people who do it are doing it frequently, so they're quite good at it. And now, obviously, if you can imagine, you taking part of the stomach and wrapping it around, the overall volume of the stomach is down, right? So it does have long-term consequences of how people eat and how they do their, eat their meals and how much quantity of food they can eat, etc. You have to be mindful of that, because if you start scarfing down like 2 burgers after you have this procedure, once everything's healed up and everything, you're going to have problems, right? There is some level of restriction from, decreasing the stomach volume and, having the esophagus, essentially cushioned like that. So you have to be careful. People can have a lot of pain and a lot of problems if they're not following the instructions post-procedure, but that's a really cool one that can be done. Another one that's pretty cool is called the LINX procedure, and I've also been able to see this myself a few times. So on the left, you'll see some picture there. It's basically same idea, reproduce or help augment therapy for the lower esophageal sphincter function. Basically, it's magnetic beads. That's essentially it. It pulls apart, so it's one straight line, and then it will come back into a full circle, and you basically go in. And again, it's a laparoscopic procedure like the other one. If there's a hiatal hernia, you can pull that down and fix that at the same time. And then you wrap these beads around the esophageal sphincter, and it helps prevent, when it's closed, it helps prevent reflux. It not quite to the same level that a NISSEN fundoplication will do, but it will be quite effective. Again, like the NISSEN, it does have some level of restriction on how you can eat. So it will dilate, right? It's a magnetic beads, it can stretch. So when you eat something, it will allow a food bolus to pass into the stomach. But again, if you're the patient, you have to counsel them. And again, you plus the surgeon, et cetera, will be counseling on this. And that's why it's important for primary care docs to be aware that these procedures exist. So you can counsel them on this and how to work afterwards, that you do have to eat smaller quantities when you have your meals. So these small frequent meals are quite important for them to adhere to, because it can cause them a lot of discomfort and pain. If they try and eat too large of a meal with this, post LINX or procedure or post NISSEN. So that is 2 things to be aware of. And those are 2 very common procedures. The LINX is fairly new. The NISSEN is quite old. And that's a very established procedure. The LINX is only a few years old. It's pretty recent. It's a pretty cool procedure that's not quite as involved as you can see by the picture as a NISSEN. So something to consider. So, if you have someone, a patient comes in, it sounds like they have very typical reflux symptoms. You tried the PPI, they failed that. They tried the H2 blocker, they failed that. They lost the weight, or they gave birth and they're no longer pregnant. They've done their activity modification by changing up their diet and they're eating healthier, all of that, and they're still having symptoms. Probably the next step for me as a primary care doc would be to refer out to GI. I would counsel them and I would say, they're probably gonna, get a better history from you. They're gonna, look back at the notes and see what we've done and making sure we've done an adequate trial of these medications. They're probably gonna go and do an endoscopy, make sure you don't have something like a hiatal hernia. They're probably gonna do some biopsies, etc. And let's assume they go down, they don't see an ulcer, they don't see gastritis, they don't see a hernia, they take biopsies, they don't see H. pylori. They say, well, there's something going on. They're clearly having symptoms. We may or may not see some level of gastritis or inflammation in the GI tract, in the esophagus or the stomach. But clearly they're having symptoms of it. Then between the GI doc, between primary care, you can discuss, well, do we need to send you to surgery, right? Do we need to send you to the general surgeon so that they can evaluate you for one or two or other types of procedures to be done? And so let's say you send them off to a surgeon, and they say, you know what, I think you'd be a great candidate for, say, the LINX procedure. There are some things that you have to do. Now, someone can have symptoms of acid reflux. Someone can have evidence of erosions or gastritis or inflammation based off endoscopy that the GI doctor does. But again, these still this is still surgery, right? It's not nothing, and no procedure is without its risk. So you have to prove that someone has GERD, right? You have to prove that there is lower esophageal sphincter dysfunction. There's a number of tests that you can do, and I should have done slides on this. I apologize. You can do something called esophageal manometry, where you can look at the smooth muscle function of the esophagus to make sure that it actually is able to push food down. You can do food bolus testing. You can do, as I mentioned, the pH testing, where you can actually test to see if acid is up into the esophagus, because that probe gets attached to the lower part of the esophagus there. So you can do tests to indeed prove that someone does have acid reflux. And let's just say they meet all the candidates for it, then they would go ahead and do that. But again, you as primary care, you are that first line of defense. You are the person, unlike the surgeon, who they've known for years and years and years and years. So they're going to come to you and they're going to ask you, hey, they mentioned that'd be a good candidate for the LINX procedure. Are you familiar with it at all? Have you had other patients that have it? What's your experience with it? And so, being familiar with this procedure as something that's there, and what the side effects are, what the follow-up is, what the risk is, how it works, etc. You may give the exact same speech that the surgeon's giving them, but they may trust you more and they may be reassured by giving the same thing. So it's good to be aware of this type of stuff. So that's the long and short of ulcers, gastritis, and GERD, what it means, what the terms are, some of the medications we use to treat these things, and some of the procedures that can be done for it. Questions?
So you guys can unmute yourselves if you want, or you can post in the chat and I can read it out to Dr. Mittal. But I can start off. I want to ask, so I know you're very active on TikTok. For those of you who aren't following Dr. Mittal, I would recommend.
Not lately, but yeah.
They're my go-to for like if I'm taking a break from studying. But I wanted to ask, what impact do you think social media has had on the medical field?
There's it's good and bad, right? You pick your poison. I think it's a generational thing, right? People like our parents in their 50s and 60s generally aren't, they don't have Instagram pages, they don't have YouTube channels, they aren't doing hosting podcasts and TikTok, etc., things like that. So I think it's more of a millennial early millennial, late millennial, Gen Z type thing. I don't know that a lot of Gen Zs are quite to this stage yet, but I'd say it's more a generational thing. So it's increasingly becoming important. And in our parents' day and age, they used to have tons of textbooks that they'd carry around for every single subject, and that's just not the case anymore, right? We have our phones, right? We look stuff up online. We do, we're all guilty of it, right? We don't go to class and we do our lectures online, even pre-COVID, right? We would do that. That's a very common thing in med school. There's so many people that for board studying, they don't use just their med school stuff. They use these online resources and podcasts, things like that. A lot of, once you finish that stage and you're in residency and beyond, people keep up their skills by doing podcasts and watching YouTube videos from well-renowned people, etc. So I think social media is it's a great tool. There's people that obviously go on this that can give misinformation, or people that aren't qualified to give their stuff, but generally I would say people get a lot of great information from social media. And there are some people on TikTok that are doing more educational things. There are people that are doing more kind of humor, which is more what I do. I don't really do more of the medical education stuff on my social media, but I think it's really important. It'll be even more so increasingly become a resource for not just education, but also humor and things like that as well.
So we have a couple questions in the chat. Charles asked, what are some misconceptions that you either have come across or have heard from others surrounding primary care?
Opening a can of worms there. So, people say, people with low board scores are the ones who go into primary care, or, they're the phrase that people say a lot is jack of all trades, master of none. You know a little bit of everything, but you're not an expert in anything. They refer everything. They're just the gatekeepers. They don't actually do anything. All they do is, triage the patient and refer them to the specialists. And, I don't think that these stereotypes came about for no reason, right? There's always some level of truth behind where we have all these types of things. And, in defense of primary care, I will say it, because I am primary care. It's hard. If I have a patient panel of 3,000 patients, and every day I have, a few hundred patients messaging me, that's a lot. And sometimes it's like, okay, I saw you for your knee pain and you're not getting better, and I've tried this and you're still not getting better. So I tried something else and you're still not getting better. And you keep saying you have pain, like something's going on, but I have, literally thousands of other patients. So at that point, I am just gonna put the referral in. And so sometimes what specialists may say, it's okay, well, this guy, he hasn't really done anything. He hasn't tried this or this or this. He's just referring. So, that there's a portion. So I would say those are some of the very common stereotypes that people say. They weren't smart enough to get into a specialty. They weren't smart enough to get into like dermatology or ophthalmology or general surgery. So, that's why they went to primary care. So that's a lot of it. And, I think more increasingly, that's more of a thing that happens when you're younger, right? People say, oh, you're the bottom of your class, you're going to end up in primary care, or I'm the top of my class, I'm going to end up in a specialty. So it happens at the med school level, it happens at the residency level. And now that I'm done with all that and I'm at the attending level, I don't know, you don't really see too much of that anymore. It does happen a little bit here and there. There is some of that toxic personalities in medicine, especially with the older generation. People have their chips on their shoulders, but I would say it's, now that I'm at this stage more, it's a lot less, which is really nice.
Thank you for answering that. I know it's a little bit of a loaded question, but
Yeah, it's all good.
From Bethany, we have, why did you choose to specialize in family medicine?
So I was originally going to go into ER, actually. And most of my med school rotations in 30, actually all of my third year in med school, I really was just hyper focused on that. And I had done pretty much all my electives, multiple rotations in my fourth year for ER. And the more and more I did it, I realized it wasn't for me for a variety of reasons. I love ER. I still love ER. I did most of my electives in residency in ER because I enjoy it so much. But, I realized in med school that it wasn't, the more I did it, it was only through doing like so many months of it, I realized it wasn't exactly the type of care that I wanted to give. It's not that I disliked ER care, but there was more that I wanted to do. there was also the lifestyle aspect of it. I came to realize that for me personally, that lifestyle of having to work nights, having to work weekends and holidays, and someday your shift starts at 10 a.m. and sometimes your shift starts at 1 p.m. and sometimes your shift starts at 3 a.m. And I was like, I don't want to do that. I don't want to do that for the next 30, 40 years of my life. So I was like, I can get some level of that more acute care through something like urgent care through family medicine, and maintain a lifestyle. So those are the two big reasons I ended up switching. And I'm really glad I did. It ended up being the right move for me. And I really enjoy it.
Great. Thank you so much for answering again. So we have a question from Omar. They asked, is it reasonable to be able to sustain hobbies during med school and residency?
So I personally struggled with that a little bit. And that's something now that residency does. I know things are a little bit hard right now with COVID, so things are crazy busy. But social media became recently one of my more hobbies, and being a little bit more involved in doing stuff like this. But each to their own. Some people have a harder time with it than others. It does depend on your specialty a little bit, right? I mean, if you're a general surgeon and you're on a month where you're taking call, and you wake up at 2 a.m. because you have to go in for a procedure. And let's say your normal routine is to wake up at 5 a.m. before your shift and do a workout. You probably aren't doing it that day, or, et cetera, things like that. So, I think it is difficult. It's difficult for most people. Um, and that's what in mental health and wellness is becoming more and more of a focus, where it wasn't, say, 10, 15 years ago, 20 years ago. So many programs in ACGME and AOA curriculums and guidelines do make that a priority for programs to address to medical students and especially residents. So again, I personally struggled with it. I found myself at the end of residency thinking like, oh my gosh, suddenly I'm gonna be having my more traditional 40 to 50 hours a week instead of the closer to 80-hour a week work months. And it's like, what am I gonna do with all my free time? It's like almost like I don't even remember what I even used to do to have fun. So it is hard, but you rediscover it, and that's just part of the path. Unfortunately, is you are going to lose some of that, but you'll get to a point at some stage, if you get through it, that you will have that free time again, that you'll be able to rediscover those same hobbies or find new ones.
Thank you for answering. I have a question. So what
Mhm.
traits do you think make a successful family physician?
So, I think it varies on where you are in your stage of your career, right? So, if you're a med student and you're thinking about family medicine, and let's say you do a 1 or 2 month rotation on family medicine, it's really hard to grasp what it means to be a family medicine doc after, a 1 month of a rotation in med school. Again, the jack of all trades, master of none thing. I mean, that holds true in that, unlike, say, a GI doc who does just gastrointestinal diseases, we do everything. We do cardiology, we do nephrology, we do GI, we do infectious disease, we do all of those things for adults. We do all of those things for kids. We do women's health. We do some levels, many docs or some docs will do some level of OB, obstetrics, pregnancy care as well. We do dermatology, we do biopsies, we do minor procedures, we do podiatry procedures, we do all of this stuff. And so I probably at some point I'm going to forget the questions. You'll have to ask me again if because I probably lost track of my thoughts here. But we do. What was the question, by the way? I'm sorry.
You're fine. I asked what traits do you think make a
Oh,
successful?
oh, oh, oh. So, at this stage when you become an attending and, you've gone through your training and you're learning to perfect your trade and become very comfortable in your medical knowledge, or when you're after that stage, these things can become fairly autopilot in general. And so primary care is hard in that you have anywhere between 10 to 20 minutes to see a patient. And that includes them checking in, them getting their vitals taken by the nurse, them being roomed, you seeing them, you talking to them, you coming up with a plan, you discussing the plan with them, and you writing their note and sending them out of there. And then you have the next patient. So it's nonstop. It's extremely fast paced. And so, I think it's hard to grasp what it means to be a good physician as a med student because your preceptors are often so busy that they don't have time to show you these things. And because it's so autopilot and you're so early on in your experience, you don't catch certain things. So, for example, being able to listen to a patient. This is something they teach heavily in primary care residency, particularly family medicine, as well as in med school, is how to learn to listen to a patient. And they have all the statistics out there where they talk about how physicians will just, they'll interrupt their patients, right? We are so conditioned to want to fix things and to give advice, etc., that we just patient will say something and within the first few sentences you're like, I know exactly what's going on, I know what their disease process is, let me interrupt you and tell you, okay, stop, I know what this is what we're going to do, right? You can't do that, so you have to learn how to listen. That's a very important part. And you go through your med school training and you'll go through these patient simulations, and you'll find when you look back at these recordings of yourself with these simulated patient encounters that if you really sit and listen, it'll seem like forever. Right? You think it's like, oh my God, I'm just sitting here and this patient won't stop talking. And then you go back and you watch these simulated videos, and they're really only talking for about 2 minutes, truly. So it's really not that long, and it can feel like forever, because like you have every single patient, with some variations. They say generally kind of the same thing over and over and over again. So it kind of gets a little repetitive for the physician. So I would say learning how to listen and stay engaged is really important. Um, Medical knowledge, right? Yes, it's important to have medical knowledge that's strong in any specialty, but that doesn't make you a good doctor, right? It's not just that, it's also work efficiency. You can be the smartest guy out there, but let's say your shift is from 8 a.m. to 5 p.m. And again, you're the top GERD, primary care resource physician, whatever in the country, right? But you're so slow at writing your notes that your family gets mad at you because you come home at 8 p.m. every day, even though you should have been home at 5:30, because you're so inefficient. You're so slow at writing your notes because you never developed that skill. Well, that creates a lot of personal strain on the physician and their family members because they're never home. They get in trouble with administration because they're in basket with all their patient messages just so backed up because they can't keep up with it because, again, they're so inefficient. Um, People's pay can get docked, people can get fired for that. So I would say it's not just the medical knowledge. When you go through your training in med school and residency, you have to learn how to be efficient. You have to learn how to play the game because that does play a part. That does play a part. So I would say medical knowledge, efficiency, obviously empathy. You have to learn how to empathize with your patients. Just because the patient number one came in that just broke their ankle and they have a fractured ankle and they're going in for surgery in a few days and they're coming in to see you, and someone else is coming in for a little bit of back pain because they pulled a muscle, you may think, oh man, that guy just pulled his muscle, why is he complaining, right? I have patients that broke bones, that come in. So you can't say that, right? You can't come across like that. Everyone's pain level is different, everyone's situation is different, so you have to be empathetic to people's individual circumstances and situations. Um, what else can I say? It's customer service. Unfortunately, part of this is, right. I mean, your group, your hospital group, it's a business. That's always part of it, and so you have to retain your patients, and so you have to be nice. You have to smile. You have to, if you're running late, you have to say, "Oh, I'm sorry, I was running late. I really apologize." Right? You have to say stuff like that because with if your patients all leave because you're a jerk, you're not going to get paid, and you won't you won't have a job. So you have to have some level of customer service mentality about you, regardless of the specialty you're in, but especially in primary care. Um, let's see, those are some of them.
Yeah, thank you so much. That was like really thorough, and I enjoyed you answering that question because I know a lot of us we're trying to like make sure that we're prepared for when we get into the medical field, and what sort of traits that we need to like highlight for ourselves and for our patients. I do have a question building
Yeah.
off of the patient
Mhm.
care. So I know you have a TikTok where I think that started with me trying to be nice to patients when they call.
Yeah.
Yeah, what recommendations do you have for those of us entering the medical field who want to have good patient care skills even during tough conversations?
Well, you do get trained on some of that during med school and residency, right? They teach you how to like you do simulations of these encounters where you have the difficult patient, right? That's the title of the courses we get and the situations we get is the difficult patient. You do that encounter in that scenario over and over and over again, and you have to learn how to accommodate. And it's not that you become a doormat, right? That's not it, right? If someone is wants opiates and you do not feel comfortable, you do not think it's warranted, you can't go belly up and just start prescribing opiates to everyone, right? That doesn't work. You have to know your limits and know what you feel comfortable with. That doesn't mean you have to be rude, right? I mean, you can't yell at a patient. You can't say, well, you're a drug addict or something like that. You can't say that. That's not right. So there are ways to phrase things um, in the right way. And the what I always say to people is it's learning how to say no without saying no, right? That's a very common thing that we do, and that I was taught, that people are taught, that we teach people, is how to say no without no. So you can be annoyed, right? It's okay to get annoyed. We're all human. You're not a robot. You can get annoyed. You can get frustrated. It's allowed. That's why you have your family and your friends and your colleagues and your coworkers to vent to and talk to and things like that. But there are courses on it. There's a lot of help that you can give even after your training is done that can help you with that. Um, Etc. It's part of the process, and you do learn that. But I get typically, I would say there's just phrases that you can use that can help. So I know, for example, personally, I remember in my second year of med school, we were doing these simulated patient encounters, and our little group, we each did it one at a time, and we'd all go into a room afterwards and watch each other's recordings and critique each other. And I remember on my encounter that I don't remember exactly what the situation was, but I remember saying like, "Oh my gosh, I'm so sorry. Like that sounds awful. I'm so sorry to hear that." And I thought I was being really nice about it. And I go back to watch the video, and God, I sounded like a jerk. And I was like, "Oh my God, I thought I did not mean to come off like that." So you really do have to be cognizant of how you word things, and um, you have to be able to read the patient, read the scenario, and that just comes with practice. You are going to have problems. You are going to mess up sometimes, and you'll get a patient complaint, "Oh, that doctor was really rude," and someone will come talk to you about it, and you're like, "Oh God, I remember. Yeah, probably shouldn't have said that." Or you get into a fight with your spouse at home, or you had a flat tire on the way to work, and now you were late, and you're just flustered, and the patients can sense that, and so you just have to be aware of it, and yeah, it's an issue. And I would just say generally how to help train yourself for that as you move into this career. Just understand that you are going to have your bad times. You have to be able to recognize it. Know that you will get trained on how to deal with those situations to some degree. Know Have a little bit of insight into yourself and say, I think I'm worried about this, that I might have issues with this, or I can recognize that I have had issues with this, or I've gotten some feedback that I've had some issues with this. And I'm going to seek help. I'm going to ask my upper level residents or my attendings or my HR department or something to kind of help me learn how to talk to patients a little bit better. So again, having that insight into yourself to know that, I'm coming across as harsh. I'm coming across as judgmental, right? You have a young male or female that comes into you that said, let's just say you have a high schooler that comes into you saying that, I had unprotected sex, I think I have an STD, right? You can't make that patient feel judged, right? If you feel that you've made that patient feel judged, you've lost them, right? You've lost them, you've lost their chance to help them, etc. So you can't be judgmental. You have to be open-minded, etc. Things like that. So it's a big topic. It can be tough. I know I've messed up a few times. I can think of a few situations where I was like, I didn't say that well, or I should have said that better. Or you start getting annoyed with the patient, and you can tell that, and they can tell that you're kind of yelling at them, etc. Things like that. So it happens, but you know, you fix it, you apologize, you man up to your mistakes, and say, I'm so sorry, that encounter wasn't good. I apologize for how I worded that, etc. So be an adult about it, essentially.
All right, we're gonna take one more question before we
Sure,
close the recording. I don't know if you're able to stay after Dr. Mittal in
sure,
case anybody here has any
absolutely.
questions.
You said we had one more question?
I was gonna wait for someone to ask, but
Oh,
if
got
no
it.
one has a question, then I was wondering
Oh, wait,
what.
if no one does, I'll ask a question.
Sure.
I mean, I've been waiting to like actually unmute myself and talk because I didn't want to put
Oh,
in.
you're
Oh no, you're
totally fine.
fine.
Oh, so I actually had like multiple questions, but since we're like running short on time, I guess I'll just ask one of them. So I was gonna ask about the anti-inflammatory. I mean, what is it? And this non-steroid anti-inflammatory
Yeah,
drug.
the NSAIDs,
So
yeah.
like, yeah. So why is it that when like people take like an excess amount of it, why is it that like it results in ulcers?
That's just one of the ways that you look about the pharmacokinetics of how that medication works. It causes inflammation in the stomach. People can get inflammation in the stomach, and if you have enough exposure and enough inflammation, that can lead to an ulcer. That's just one of the very common side effects of it. It's processed through the kidneys, so anti-inflammatories. If you have decreased kidney function because of long-standing diabetes or high blood pressure, you have to be a little wary about taking these anti-inflammatories because, again, the kidneys are what process it, as opposed to Tylenol, which is processed through the liver, so it does act differently and doesn't have those same features. So that's just how the pharmacokinetics of these anti-inflammatories work.
Oh, because I was thinking it would probably be because of like I was gonna ask like, is it because it's acidic or anything in like any way? Because that can probably like lead to the acid refluxes.
To be honest, I don't remember the level of pharmacokinetics how that works. That's a good question. I would definitely look that up because I honestly don't remember off the top of my
All
head.
right.
Jack of all trades, master of none, right? I mean, that's my answer to that.
All right. Thank you so much for that incredible and insightful session, Dr. Mittal. I
Or
really
thank you for
enjoyed how
having me.
interactive you were, and I love learning more about GERD and ulcers. We hope to have a session with you again in the future. If you would
Definitely.
like to post your social media handles or links to your business endeavors in the chat, please feel free to do so. To our Wayne State University students, please make sure you complete the Google survey posted in the Zoom chat summarizing the session to obtain your shadow hours. Thank you all, and I hope you have a great night.